Center for Healthy Neighborhoods. This is our monthly seminar, and I'd like to welcome you. If you've not been here before, we're actually holding it in our PRC, our center, because it is internet heavy dependent.
Yes, it is.
For this presentation to work. Normally we meet downstairs in a larger conference room, but we thought because it's July and it might be people having conflicts with vacations, that we could go ahead and squeeze on into this room. So make yourself comfortable, make yourself cozy. Hopefully it won't get too warm in here, but please do help yourself to the nice lunch that we've offered today. So we have a seminar the second Wednesday of every month. We take August off to regroup and set the schedule for the next year. If you have topic ideas, things that you'd be interested in presenting yourself, or you have suggestions for speakers, activities that are going on locally, regionally, even nationally, go ahead and reach out to me, sueflocky@case.edu. I'd love to hear about your suggestions and ideas. We can't fit everything, but I certainly would like to know what you all would like to be hearing about. Many of you did complete a survey for us a couple of months ago. That was helpful, great feedback. It helps us guide what we're going to do and continue to do. And I'll just share with you, overall, the feedback was positive and encouraging that we ought to continue to do this seminar. We've got some seats up front. There's one in the middle. Help yourself to some lunch. So with that, I think I'm going to go ahead and introduce our speakers today. We have two speakers, and I love the tag team effort. Our first speaker is Lauren Bottoms, who is our internship coordinator and a research assistant here at the PRC. She's been with us 2 years?
Just under 2 years.
Just about 2 years, and has been a fantastic addition to the team. Has fit right in and run with it. This presentation and the task behind it was something that Elaine Borowski, the director of the PRC, had sort of inquired whether Lauren would be willing to think about it and take it on. I'm sure we'll hear a little bit more about the story, but it evolved into something quite big and quite impressive. So I'm really excited to hear more about that. And co-presenter is Andrea Martemus-Peters, who actually serves on our NOCA currently, which is our network of community advisors, and has been involved in this and helping to guide this presentation and the usefulness in this work of these data. So what we're going to hear about is the behavioral risk factor surveillance system, and not just that, but the platform that's been created to make these data more accessible, more shareable, more interactive. So with that, Lauren,
thank you, Sue.
Who's going to go first?
Yes, it's me. Thank you, everybody. Can you guys see the screen pretty well? Should I turn off a light? Okay.
Is that better or is that too dark?
I think it's fine.
Okay.
You guys are good? Okay. So thank you, Sue, for the introduction. So you guys see the title is If We Want to Know, We Have to Ask. And this will be a recurring statement throughout the talk because surveillance is only as good as the questions we ask, right? So again, thank you guys for letting me come in and share this new and exciting data with you. It has been a work in progress for quite some time now. Elaine tasked me with analyzing some of the data, and it just turned into a complete new website. So that's what you guys are going to see today. During today's presentation, I hope to provide an overview of the behavioral risk factor surveillance system at the national and state levels, as well as how it came to Cleveland and Cuyahoga County. I want to share the importance and the benefits of having such a surveillance system, as well as how it can be used in community-based work and research. Then one of our network of community advisors, Andrea, will come up and talk about the role of NOCA in this process. And then lastly, I will unveil the new Brfss website, share some of the new data, and show how you can access it. This talk will be slightly different from past talks because I want to leave a lot of room for discussion, and we will explore the website in detail. So first I want to start with the history or background of the Brfss as a national system. So the behavioral risk factor surveillance system was the first of its kind to collect state health data via telephone surveys in the 80s. It was established by the Centers for Disease Control and Prevention and allows for the collection of standardized information that covers a wide range of health-related behaviors and chronic conditions. This surveillance system that actually started with only 15 states participating in the 80s is currently collected in all 50 states, the District of Columbia, and 3 U.S. territories. And they complete over 400,000 adult surveys each year. This is the largest continuously conducted health survey system in the world, and due to its long-standing power, the Brfss is considered a vital surveillance tool that allows for trends and comparisons to other populations, as well as guides research and programmatic efforts. So the behavioral risk factor surveillance system is made up of a series of surveys, and in the acronym, the last S on Brfss can refer to either surveillance or survey. So for example, when I'm talking about the 2015 Brfss, I'm focusing on one survey. When I talk about the local Brfss website as a whole, I'm talking about the Brfss as a system comprised of our local surveys. So the National Brfss questionnaire has 3 parts: the core questions, the optional modules, and the state-added questions. The core section is the standard part of the survey. And these questions are asked without modification of any wording and are asked at all levels, national, state, and local. These kinds of questions include information such as demographics, chronic health conditions, tobacco use, and health status. I will get more into the importance of the core questions later on in the talk. Next, you have the optional modules. And these questions are jointly created by the state and the CDC and are not required to be asked by all states. And lastly, we have the state-added questions, which are not offered as core or optional modules, but are rather based on states' interests in certain topics, in certain topic areas that are specific to that state's programmatic needs. So like I previously stated, the Brfss is conducted in every state. The Ohio Department of Health has implemented the Brfss since its conception in the 80s with the help of the CDC. The Ohio Department of Health wanted to have a consistent surveillance tool to monitor health behaviors, specifically those behaviors that lead to preventable morbidity and mortality in the adult population, such as cancer and diabetes. ODH conducts the Brfss annually with continuous surveys to capture all seasons and historical events. An outside contractor, which is normally a call center, conducts 700 to 1,000 interviews per month. Matching the national survey, Ohio's survey also has 3 parts: the core, optional modules, and state-added questions. Only this time, the optional modules and state-added questions are chosen by the state of Ohio based on topic areas of interest to their program and efforts. So how does this translate to our local community? How did the Brfss come to Cuyahoga County in Cleveland? So Ohio oversamples counties and cities. They do it by regions, right? They break it up to get a sample based on just the regional estimates. But sample sizes are never large enough for local use, nor diverse enough to capture our geographic region or demographic diversity. If we wanted to know what was going on in Cuyahoga County and Cleveland, we had to ask the questions ourselves. So through tobacco-related funding, the Cuyahoga County Brfss was conducted from 2003 to 2007, while the Cleveland Brfss was conducted through Steps to a Healthier Cleveland between 2005 and 2009. The PRCHN hired ICF, which is an expert survey research group that conducts surveys all over the country. This is the same call center that the state actually uses. And here at the PRC, we manage and monitor the data and administration of the surveys while they are in the field making the phone calls. So in 2009, the PRCHN then used their funding to combine data sources to create neighborhood cluster estimates within the city of Cleveland. So we took the data from 2005 and 2009, combined them, and came up with 7 neighborhood clusters. And during this period, we produced a number of data briefs. And although these data briefs were released from 2009 to about 2012, there was a lag in funding, and we were not able to administer the Brfss during this time. However, in 2014-2015, we were able to administer a Cleveland-only Brfss with in-depth neighborhood data collected. This administration was made possible with funding from the St. Luke's Foundation, Case Western Reserve University School of Medicine Dean's Office, and the Angela Bowen Williamson Endowment. So a huge shout out and thank you goes to them, because without that, this would not be possible. So our goal is to repeat this administration every 2 to 3 years. I'm being optimistic, and I'm saying 2018 will be the next administration, right? And we need this to be administered every 2 to 3 years so we can aggregate the years to get neighborhood-specific data. So now that you've heard some background on what the BRFSS is and its history in the community, why do we need it, right? What's the purpose of having this tool available? Well, it's an important aspect of our research. Because we have this data and have collected it for a while, we can track real-time information and trends in Cleveland. For example, with this system, we can actually see real-life events reflected in the trend data. We have the ability to include questions that are important to us and our community, and it also helps guide our research and program development. Having this surveillance system helps us determine what areas we need to focus on, as well as provide strong objective data on whether our community efforts are working. I cannot talk about the history of the BRFSS in Cleveland without talking about our network of community advisors, or NOCA. They have played a large role in this entire BRFSS data process, from picking the questions to go on the questionnaire, all the way through best ways on disseminating the data. So right now, I want to turn this over to Andrea for her to talk about NOCA and their role.
Thank you. Well, good afternoon, and thank you. Thank you, Lauren. So my disclaimer is thank you so much, Lauren. When I got the email from Lauren a few weeks ago and asked me to co-present with her, I was absolutely floored. I thought she sent it to the wrong person. And it has been a pleasure working with her. I just love, her mind is just so busy. And, when we got to the electronics part, I'm going to turn it back over to Lauren. Okay. So, again, as Lauren said, we're going to keep this relaxed and brief, because you're here to really see what Lauren and the whole PRC team has been working on. But first, I want to acknowledge that the network of community advisors. And who are we? Well, we're a diverse board of people. We're passionate about our community because we live and we work in it. And NOCA is comprised of the 3 committees that we have here: the governance, the research, and the community ties. So if I can have a hand representative of our NOCA members. So thank you for coming out, because we all had a hand in this. I'm with the Community Ties Committee. So we have a desire to improve the health and wellness of our community with their input. So we can't just come in and say, this is what you need. We really want to make sure we're reflecting the needs of the community. And we know that it's essential to include them in the decision-making process and in regards to their health impact and things related to their community, because we want them to work side by side. Again, we don't want big entities coming in and telling them what we think they need to do. So we encourage the community leaders to take leadership roles in their neighborhood. So these are people, our neighbors, who probably may not have as much academic experience as us, but we're working side by side with them. And we know of all the different organizations throughout the city who offer leadership type of training. So with NOCA, we have our committees are mixed with academia, community leaders, nurses, we have schools, we have the colleges, we also have the Cleveland Public Schools representatives. So we are a mixture of everything and everybody. And we try to include our local government as well. So whenever we are having our big dissemination events, we all break up in groups and we figure out who are we going to tag to make sure that we get them to our dissemination days. And we want them there at those events because they need to hear from our community members as well. So again, we're not coming in and telling them what they need. We want to work side by side. We want them to identify their strengths and their areas of needs and where we can work side by side to help improve them. And many of them, again, as I said, we live amongst our community members. So why are we investing in this partnership? Because we do need each other. Together we are much more successful. So the PRC works together with the community partners on developing appropriate interventions and strategies for addressing the disparities and inequities that exist in our communities. So to do that, we have to have that local data that Lauren is going to bring about. We know that the data drives our outcomes. It's big on funding, and we want to have it as current as possible. So the 2015 survey brought the Community Ties Committee together so that we were able to review the questions and look at that, and we had a lot of conversations behind it. So the community input was also important in the development of the research questions. And we have to ask the right questions in order to address the issues that are really affecting our community. So for example, we have the tobacco use question. For many years it was just cigarettes and chewing tobacco, but also our Community Ties Committee recognized that not all of our communities, that's not the only things that they use. So little cigars was introduced, and we found that we are ahead of some of the national surveys with that. So we're glad to be a part of that. So as previously mentioned, the tobacco questions, they needed to be updated, and so we added the little cigar questions. We talked during our group discussions in the NOCA Ties about capturing how it is living in the city of Cleveland. So we talked about quality of life questions, questions that were around hopefulness, and what do people foresee living in the city of Cleveland, what are their aspirations for their community. So NOCA uses this information, and we wanted to make sure it had relevance to the community. We wanted to focus on questions that would benefit the community and not only the researchers. So in talking with my fellow NOCA committee members, we know in the past that a lot of times the research is really only helping the researcher. So we feel that this data is helping to bring what the researchers need, but what our community members need and what our community leaders need to come together and bring out about good outcomes. So Lauren, as she came and presented to us at one of our meetings, one of our Community Ties meetings, we were able to give her feedback on color, design, content, making sure it is something that is user-friendly, making sure that the colors are bright, or the script. We did all of that, and this is what Lauren has worked on. And I'm going to turn it back over to Lauren so we can get to the meat of this presentation.
This is what you guys Thank you so much. That was good. That was good. Let me get my stuff together. Okay. So you have heard of NOCA's role in this process and the benefits of having such a system. Andrea talked about how important it is to ask the right questions to ensure we are intentional in our research and programs, as well as the populations we want to focus on. To talk about where the BRFSS is now, it is important to show where it came from. So before I unveil the data, I want to talk about the older version of the BRFSS website. So here's a screenshot of the intro page from the old website. It's very text heavy. It's in paragraph form. And this introduction gives the audience an overview of the CDC BRFSS. This paragraph gives you a little bit of the methodology, such as how long the administrations would take and the response rates. And then we have some information here about the local BRFSS. And lastly, we have a link to download the data briefs. It is very general and does not go into much detail about our community and the data provided for each survey. So this is all that was there on the older page. And the information is there, but we could dig deeper, right? I also wanted to touch on one other limitation of the older website. You can see how the data is separated by year on the side. This is where you would find the BRFSS data by each year of survey administration. I want to show you an example with 2009 BRFSS data, which was our last administration before 2015. So you click on 2009 in that corner right there. You see a small blurb that describes the methodology behind the survey, how many complete usable surveys, response rates, and administration period. And on the left side, you see each topic area listed. Clicking on each topic area will reveal the data. So for example, if I were to click on healthcare coverage, the data would pop up. If you clicked on obesity, another window with obesity data would pop up. Each data topic has Cleveland compared to the county, Ohio, and the nation where applicable. So I don't want to downplay this old website because the thing is, it served its purpose, right? The dissemination, getting the data out there for the public to see. They can access it, and that's what's important. However, the data is only presented in one way. So for example, the way the data was presented, it's difficult to see trend data in side-by-side comparisons. Let's say you wanted trend data for obesity. You click on 2009, you put down 35%, then you have to click on 2008 and go back and do it all over again, right? Not very efficient. Ooh, I gave you guys a little sneak peek. So within the past year, I've been working on designing a more user-friendly, more accessible, and more sustainable BRFSS website. So first, I will show you guys a couple of screenshots from the new website, and then we will go live and dive into the data on the actual website. And that's why I needed to be up here, because I needed the internet to work for this. So here's the updated intro page. And as you can see, the aesthetics and content have changed. The text is broken down into several sections with more color and bolded text. We got away from the paragraph form towards the bottom there. And there are also embedded links throughout. The content, which you guys can also see when we go on the live website, is more about the history on the development of our local BRFSS and gives insights into the kinds of core and local questions we ask. It also gives some direction about the website. We talk about using the menu on the left to find what you are looking for. So already, this intro page is giving you some more detailed information about the local Cleveland BRFSS. Lastly, there is an option about a data inquiry. Let's say you have a question about the data or need some charts created, or you want to see the data stratified in a certain way. You would click here on the right side and it would take you to a data inquiry page, which looks like this. Once all the fields have been entered and submitted, I will receive an email and will contact you within 72 hours. That's what I'm giving myself. Hopefully it'll be sooner than that, but no longer than 3 days. This is helpful, having a page that is strictly for data questions and allows for a systematic way to disseminate the data in a timely manner. Before this process came about, the data question had to go through many channels before the request was fulfilled. This form prevents that from happening. You can also access this form on the left side of the menu. Another important limitation with the older BRFSS website was, although it touched on the methodology behind the administration and the data protocols, it did not give an in-depth picture of the overall BRFSS methodology. This new methodology page will be updated each BRFSS survey year and will describe how the data was collected, sampled, aggregated, and weighted, as well as provides access to the original methodology reports. This page is for those who want to view the behind-the-scenes components of the surveillance tool itself. This area below also gives you access to the current BRFSS survey year questionnaire, as well as links to past questionnaires. So this page already has a lot of information on it, and we'll go into this page once we go live. Talk about this in more detail. But this is the page that everyone will go to first, right? This is the landing page of the 2015 BRFSS data. This page shows the different ways you can view the data. And from here you can access it in the way in which you would like. By trend, themed data for the current survey year, themed data broken up into demographics, and lastly, viewing the data, comparing it to state and the nation. So what did the 2015 data tell us? I'm going to take you through the website now and show you the most efficient way to use it, and then we can focus on some things you guys want to see. All right, look at that working. Wonderful. People who have been here for a while know this is a great thing, right? Okay, so again, we're at the intro page. So you can definitely see now it is a lot brighter. The text is broken up. You see the core questions that we focus on. I don't think this thing will. Yeah, I don't think that thing will work. Okay. Yeah. So the core questions, these are the questions that we can compare to the state and the nation. These are questions that we probably have trend data on because it's been collected for more than 3 years. But you also see we have the local questions: perceptions of neighborhood food availability, price and quality, neighborhood safety, quality of life and support, hopefulness for family in the city of Cleveland. These are questions that are focusing on how it is to really live in Cleveland. And there's some good information in here. We'll get into that. But also, let's say you see, okay, health quality of life, healthcare access and utilization. You want to see what questions were asked in what years. So we have this chart up here. You can see the topic areas, the questions. Actually, I'm going to do this. Topic area, questions, and then the years in which they were asked. You see some were asked each year the BRFSS was administered, and you see we added some new, you see we added some new questions, haven't been asked that many times, and then these are all brand new. So this is at your fingertips. You guys have access to this. Let me bring it up here. If you scroll back up, this is the data inquiry page. You click there, or you can also access it here. Again, I'll give you guys some information on, or I'll give you guys examples on some data questions you could ask me. So for example, if you wanted to see black males age 55 to 64, the prevalence of diabetes in those black males. So I did stratify the data, but it wasn't broken down into that much depth. So that's an example of a question you would ask. And I would be able to run that for you. We go back to the main page. I also want to touch on one other thing. Here's the methodology page. And this is what I wanted to show you guys. It talks about ICF, since it's been conducted in the PRC. So 5 talks about ICF conducting the survey in both Spanish and English, how long the survey actually took, and the response rate, right? And also talks about how the answers were aggregated and weighted. These are the survey years. This is the sample size, number of complete and valid usable surveys. And this is what this sample was weighted to represent, these many people. I can get into that if you guys want to talk about this in the discussion. But let's say you don't understand this. Guess what you can do? You can click and you have access to the full methodology report, sample design, how many completes there were, what was the protocol, the topics. It's all at your fingertips. Let's say you saw a number in the data that you didn't quite understand. You wanted to see how they asked the question, right? That's a big question. If you see a number, you're like, well, how did they ask that question? Look what you can do. You have access to that, okay? You have the script itself with all the topics right here. So you can see how we asked the question. You can see how uniform it was. Every call that was made went through this protocol to get the data. So you have this available. But this is what you guys really want to see, right? This data itself presented in 4 ways: trend, themed, demographics, and comparisons between local and state. So when you click on View Trend Data Modules, you see a circle with a whole bunch of mini circles in it. We're going to call these mini circles buckets. And these buckets each represent a topic area. You see there are 7 topic areas for the trend data, and like I said, these are for variables that have been collected over a period of time. You click on themed. Again, you circle with the buckets in it, but you see there are a lot more buckets and topic areas in this piece, and that's because we added on the local questions, right? We asked a lot more local questions this time than any other year. And we'll go into some of those. So hopefulness and support is new. Neighborhoods is new. Food security and shopping patterns, that's new. And then we have the data modules by demographics. It's around the same number of buckets as the theme data. And that's because literally what I did with the theme data is I took each health indicator and I broke it down by gender, race, age, income, and education. As broken down as I could. We don't want to make the data unstable. But so that's why there are about the same number of buckets here as themed. National and statewide comparisons. You see there's only five buckets, right? And that's because, again, these represent those local, those core questions of the BRFSS. So now I want to take you on a journey of healthcare. And I'm going to go through how you would use this data in all 4 ways. You click on a bucket, and this is what pops up. So for people who like a table, there's the years up top, healthcare coverage, the topic, and then the prevalence or percentage with a confidence interval. These are for people who like to see significance. You know, if the confidence intervals overlap, it's not significant. If they don't overlap, it's significant. For people who want a visual representation of the data, I also provided a bar chart. So what do you guys see here? What do you guys see here? Right? This is an example of how I said you could see real life events reflected in this trend data. So the recession hit hard around here, right? And you see that reflected in the data. ACA happened around here, shoot up. And it's significant, right? So all of the health indicators that were under what I considered healthcare, they're on this page. So have at least one personal doctor or healthcare provider. Again, you have a table, and then you have the visual representation or the graphic. And not much difference there. It's way lower than this number. But the good thing about this surveillance tool is it's to help inform us on the issues that are going on. After each page, there is a table, you know, what the table summarizes, how many Cleveland adults this data is talking about, and then takes you a link to the methodology if you want to learn a little bit more. Had a routine checkup within the last 12 months. That's gone up a bit, you think? Yeah. And this might also have to do with the ACA or with people having health care now. They are actually having a routine checkup within the last 12 months. Or maybe they're saying they have a routine checkup because they went to urgent care or the ER, and that's where they're getting their checkup. And that is what you see for health care. So this is showing the data over time. I'm going to leave that up. I'm going to go to themed. I'm going to click on healthcare. Make it a little bigger. Data is presented in a couple different ways now. There is a difference between the themed data and the trend data. For the themed data, I left it pretty much as is. All the answers I left as is, and I provided another graphical representation for people who like the visuals. So do you have any healthcare coverage? We've seen that number before, 87%. And you see a visual representation. Do you have one person you think of as your personal doctor or healthcare provider? We've seen 74.3% before. Ooh, woo-hoo. Now this is a little bit different. The question in the trend data was, have you seen a doctor in the past 12 months? But the question was, about how long has it been since you last visited a doctor for a routine checkup? We've seen the 75.2% that was on the trend data. But now you see it broken up into the other answers. So 11.5% went to the doctor within 1 to 2 years. So about a little under 90% have been to the doctor in the past 2 years. It's not a bad number. 75.2%, 3 out of 4 people. Okay? And this is something else that's different. So now this question is about how long has it been since you last visited a dentist for a routine checkup? This was the first year we asked about oral care. So if you just looked at the trend data, you would not know that we asked about this question, right? And you see it's low. 57.4% have seen a dentist in the past year. The next largest number is 15.4%, which is 5 or more years since they've been to the dentist. Okay? So that's why the theme data is a little bit different from the trend. You get to see all the different options. Okay? So let's say you see this number and you're like, well, I really want to see it broken down even more. Like, which groups aren't going to the dentist? Which groups aren't getting those routine checkups? Demographics. This is where this comes in. Okay. So the way the demographics are shown, they're just in tables. It's very hard to make visual representations for each one of these, but that's a data inquiry. You can ask me that, and I can run this for you and create a chart or table for you. So the way this is shown, oh, that's nice and big. Okay. And believe me, it's easier to see on your laptop, on your desktop at home or work, or if you print it out, I promise it's easy to see because Noka and I talked about that. So I showed the topic, the overall Cleveland population, what the overall Cleveland population is. The demographics on the side, the prevalence or percentage, and then the 95% confidence intervals to see the significance between the groups. Okay, it's good, I think. So, what do you guys see here? Men and women, there's a significant difference between men and women on those who have health care coverage. More whites have health care coverage. They're over the overall Cleveland population. Of course, those 65 and up, more likely to have health care coverage with Medicare. You would expect those who make more than $50,000 to have health care coverage. 96% of them do, way more than the overall Cleveland population. Not much difference in education, but of course, those with a college degree probably have a higher prevalence. Have at least one personal doctor. Look at the disparity between men and women for those who have one personal doctor. Something we know, right? Something that's been studied and reported. Men don't go to the doctor necessarily. Don't go to the doctor as much as we do. We're always pushing them to go to the doctor, right? Whites are more, but there's no significance really there. We would expect this, right? Again, no shock there. Expect that. But young people, only 61%, 18 to 44. If you guys have any questions about why I categorized the data the way I did, we can talk about that in the discussion. Had a routine checkup in the past 12 months. So you see, I'm focusing more on what we asked in 2015, not what the trend data represents. I wanted to show the demographics broken down into the most current survey year. Had a routine checkup in the past 12 months. 82.1% of women compared to 67.2% of men. Okay? Huge disparity with that. But this is interesting. Those who make less than $25,000 it's not significantly higher, but the prevalence is higher, right? Had a routine checkup in the past 12 months. Why do you think that is? Things are wrong with them, yeah.
County medical or something?
County, yeah. Probably urgent care or the ER. It's what they're going to, and they might have considered that in a checkup, right? They got checked out when they went. Dentist. Had a routine dentist visit in the past 12 months. It's all low, except those who make more than $50,000. Over 20% higher. Right? But we would expect that's probably with insurance, with their coverage at their job. They cover dental. So this is an example of just how you would use the demographic information, right? I have my statement and my logos. And then lastly, let's say you want to say, okay, well, how are we doing compared to the state and the nation with healthcare? This data is presented again as a table. Cleveland, Ohio, United States, the prevalence or percentage, and the confidence intervals, and a chart. 87%, that was the highest we had in Cleveland in a long time, right? Significantly lower than Ohio, not by that much, but significant. That number may increase, if we could get this in 2018. I'm going to keep plugging. 2018, if we can get an administration here, we might be able to see a change in this. I think we'll start, I think we've seen an increase. Hopefully it stays increasing. Have at least one personal doctor or healthcare provider. Again, still a little bit lower, right? But again, this is just here for you guys to view, to inform you, and then you guys will go off and do have programs and interventions to address some of these issues. Had a routine checkup within the last 12 months. Higher here. Interesting, right? And so that's really it. So again, they did not include any oral care questions. So again, you're really limited with the trend data and the nation and state comparisons. So what I suggest is I would start with the themed data modules to see all the questions that we really asked for the BRFSS. And then I would look at the trend, then the demographics, then the comparisons. But now I want to show you something a little bit different, a local question that we wanted to ask that will only be under the themed and the data modules by demographics. Hopefulness and support. Again, with the themed, I left the answers pretty much as they were. I wanted to get an accurate picture. So when I look to the future for me and my family, I'm hopeful for good things to come. 89% of Cleveland residents are hopeful, which is great. When I look to the future for the city of Cleveland, I am hopeful for good things to come. 81%. These are high numbers considering the fact that we hear such bad things about Cleveland all the time. They're poor, a lot of crime, they don't have insurance, things like that. We're hopeful. I think that talks to our resilience, you know, the Browns will win the Super Bowl type thing. Do you have at least one person you could turn to for emotional support? 88.2% feel like they can turn to somebody for emotional support, while 87% feel like they could turn to someone for instrumental support, helping them do things, you know. And lastly, in the last 12 months, were you worried or stressed about having enough money to pay your rent or mortgage? So this is what's interesting to me. 50% say no, but you see there's right down the middle. 50% feel often or sometimes that they are stressed about paying their rent or mortgage. It's almost a quarter even. Total family income is enough for you and your family. Very comfortable, comfortable, not too comfortable, not at all comfortable. Large portion of people aren't comfortable, but a little more than half are comfortable with their income and taking care of their family. But let's see, I bet, you know, people who make less or people who have less education, that goes way down. It's about 65%, right? I don't believe they're hopeful or they feel like they have support. Again, we have the overall Cleveland population of 88.2. Not much different. Nobody, no matter what the group is, we're still over 84%, 83% of people that feel like they can at least turn to someone for emotional support. That's good. It does vary a little bit, of course. For example, you know, those who make less than $25,000, it goes down a bit from the overall. But still, 85.8% of them feel like they have someone they can turn to, and that's great. Again, same kind of pattern with the instrumental support. You would expect some would, you know, of course, those who make more than $50,000 feel like they have someone they can probably, they feel supported. But still, they're pretty high numbers considering. And then hopefulness for the future of myself and my family. 89.2% overall Cleveland. Number does not really change at all in the in the different groups. There are some, again, less than 25,000, it goes down a little bit, but still 86.8% are hopeful for their future of their family. Same pattern with Cleveland. It goes down a bit, but the overall Cleveland population went down a bit when talking about being hopeful for Cleveland. Okay? And that's interesting because, yeah, a lot more blacks and Hispanics are more hopeful for the future of their family and a lot more hopeful for the future for the city of Cleveland. I think that's interesting. Worried or stressed about having enough money to pay your rent or mortgage. This, you will probably, you would expect this, right? You would expect that. Blacks are more stressed. Women are more stressed. Slightly. Younger people and those, you know, under 54 are more stressed. I don't know if that has to do with paying kids college tuition. I don't know. Again, this data is just to inform, right? You can dig a little bit deeper with your programs and interventions and things like that. Total income is enough for you and your family to live comfortably. Men are like, oh yeah, my income, yeah, I feel pretty good. And that's significant. Hispanic or others feel like their income is comfortable. Of course, those 65 and up would probably feel that way. And of course, those who make $50,000 or more. This is a big disparity, but you would expect that, right? We're talking about income. So those are the two topics that I wanted to focus on because I wanted to show you guys how to go through the 4 ways that the data was presented, as well as how you would go through looking at the new local questions. So I'm going to finish up, and then we can start our discussion. And if you guys want to see other buckets, we can do that. But let me finish up. Get my papers together. So there are some next steps that we have planned for the BRFSS. And these were ideas that have been in the works for a while now, but were put on the back burner while trying to get this data out to you guys. There are a number of data briefs we want to release: chronic disease, tobacco, and quality of life. The quality of life brief will be spearheaded by our NOCA Ties committee. And we hope to get these out before the end of the year, beginning of next year. That's my goal. Another thing we want to do, there are several health indicators that we could pair with the Youth Risk Behavior Survey. And maybe we would do a twofold data brief with the BRFSS and the YRBS data. And then lastly, one of our main goals with this data is to get down to the neighborhood level, but with that we need funding for the next administration. Currently our sample is too small to aggregate the data together, and we did not weight by each neighborhood, we only weighted by Cleveland as a whole. And we all know that each neighborhood has their own demographic makeup, so no 2 people are the same in those different neighborhoods, so that's why we can't show the data at the neighborhood level just yet. But with to make this surveillance work the correct way, completing the survey annually or every 2 years is the best way to depict Cleveland, right? Clearly and correctly. We have to get this in a consistent way. So I do have some acknowledgments. Of course, the PRC for allowing me to grow and thrive here. I also want to Case Western School of Medicine because they employ me. Dr. Elaine Borowski, I want to specifically thank her for giving me this opportunity. This project, it kind of fell into my lap, and I just ran with it. She gave me the reins to run with it, and so I appreciate her for giving me this opportunity. And she wanted to tell me that she's so proud of me and that she wishes she was here. I wanted to put that out there. Network of Community Advisors. The Network of Community Advisors, I had only been at the PRC for just under 2 months when I came to present on the 2015 BRFSS data. And they were so encouraging, and they made me dig deeper into the data, and they helped me figure out the best ways to present the data so that the community, not only researchers, but that the community can understand and use this data in their work. I want to thank Andrea for being willing to present with me, and you helped me so much during the practice sessions. You made me very confident, and I appreciate your words of encouragement. Lastly, I do want to shout out Susan Patron. She is the one who helped me with those circles, those buckets, those beautiful buckets. That's something a little different, right? And there's the funding statement and questions. Let's get into some more data. Any questions? Anything else you guys want to see? Yeah.
Thank you for this great presentation.
Thank you.
You said this is a phone survey, and so I'm just wondering if, as people transition to mobile phones, things have changed, and how can we make sense of that as we compare over time?
Exactly. And so one thing we did for our Cleveland and Cuyahoga County administration, back before 2015, there weren't a lot of cell phone use, but this 2014-2015, we just went right down the middle, half landline, half cell phones. So we tried to get a better picture of those who've moved on to just the cell phone era, not, the landline. So that is described in the methodology report, but yes, it represents both. Yes, ma'am.
If you're saying that annually, or at least every 2 years, is like a good way to capture data, to look at trends, and we know that funding is an issue, how much is this project? Like, is it likely that something like this could get funded to be done annually? Is it too much work to be done annually?
It is expensive. It is expensive. The survey group that we have, ICF, they make over 100,000 calls, I believe, to get a sample size of 2,000 people that we can use, usable surveys. They do it every day. They're working every day, calling people at different times. It can be expensive. the administration itself isn't as expensive as digging down into the neighborhood level and being able to weight it based on the neighborhoods. That's where it gets expensive. It's so over 100. It's a lot, but it's not unrealistic. I mean, it's not there are places that can give us the funding for this administration. It's just trying to find, maybe bringing some foundations together or bringing someone who would sponsor this together and making it work. Yes?
Okay, sorry.
Yes.
So even with the old system, I know you did the old system versus the new system. Do we know how many organizations or our partners were tapping into that information?
So a lot of community partners and organizations, so Cuyahoga County Board of Health, Cleveland Department of Public Health, St. Luke's, I believe, all the organizations represented by NOCA. You would use some of this in your...
Especially the wire.
Yeah.
But we do tap in.
They do tap in. So a lot of our nonprofits do. And then a lot of people from academia. I remember being in school and using some of this data that was available, not only BRFSS, but the WireBS data. Yeah.
Are there other communities, cities, or counties that also have their own local surveys? And do you try to coordinate with them?
We have not tried to coordinate with them, but I know of Summit County who has done it in the past, but they haven't done a most recent one. Am I right, Erica? They haven't done Summit County, BRFSS?
I don't know that if they actually did BRFSS.
Just the youth risk behaviors?
Just YRBS. In the state, at least in Ohio, a lot of counties will rely on the state's oversample.
Yeah.
And that's sufficient. And at the state level, it's only for the counties, not for the cities. So we could get Cuyahoga, but not Cleveland. And just the sheer expense is cost prohibitive for many other communities to engage in a locally funded survey.
Yeah.
So there might be other communities that ask extra questions like Cleveland does, but they wouldn't be the same as your extra.
Yeah, we couldn't get it down to the city level, let alone the neighborhood level, which is what we would like to see. Yeah.
Speaking of the neighborhood level, I know that the 500 Cities Project data came out this year that has BRFSS down to the census tract level.
Wow.
So I'm curious how those data align with our local findings for our local area and how the two data sets are different.
Right. Wow. Yeah, I would have to look into that. I have not looked into the 500 cities, but that's good. I'm going to write that down. I don't have a pen, but I will.
Do you know if those data are going to continue across multiple years?
I think they're supposed to, but they might also have a caveat about you can't use it for longitudinal comparisons. They have some caveat in there.
Well, that's with any surveillance tool. There's caveats to all of them because really they're just looking at a snapshot in time. So depending on how that person was feeling that day when you called them could reflect in the data. Anybody, any other questions, or do you guys want to see anything else?
The response rate, I thought it was about between
25 to 30%, yeah.
How is that? Is that considered good? Or
That's common for these large landline or these large telephone surveys. That's pretty common, 25 to 30%.
I need to check that it's not, selecting a specific group.
Yeah, so they do the random digit dialing to get their participants, and there's a protocol that ICF uses, and it's actually increased the response rate. The new one that the new protocols that they're using to ensure it's kind of up that response rate. They've changed over time, so actually it's doing pretty good for these surveys. Yeah.
I was just curious on your the personalized email form you set up. In some cases, I work with nonprofits who maybe have kind of issue-specific kinds of grants they might want to get funded. And if people really weren't data people, if they didn't necessarily want to try to figure out how to find something on the website, does that form allow for someone to just kind of say, I need to talk to you on the phone, or I'm from such and such agency? I mean, is it global enough to do that?
Yes.
Okay.
That's fine, because it comes directly to me. I get it right when you press and pops up in my inbox pretty quickly. So if there's also a part to give me a deadline, that also helps. There's a section on there where you can write the deadline in, so I know kind of what I'm working with.
Okay, great. Thanks.
You guys don't want to see any data? That's what this is here for. That's what I'm here for. Yeah, Barb.
This isn't a question, but rather a comment.
Yes.
I think this hopefulness data is the most exciting stuff to come out of the PRC. I'm completely biased, but I operate from if there's no hope, there's no chance of anything. And this is so, I think, unique to Cleveland. We have to play this up big time because it does speak to our resilience. And I was laughing. I was standing in the hallway as you were presenting that, looking down the hallway, that there's still the calves defending.
Yes.
Yeah, we have to get over it. Yeah.
Right. You know, I think that, and you're right, and it's great to have something positive come. We're so used to the negative. It feels good to have something positive come out.
An entity like the Greater Cleveland Partnership, which is doing their 5-year plan, all about recruitment, retention, job development, being very, very interested in this.
Okay.
And
We'll talk, yeah. Okay, we'll talk. Yeah, Rachel, hey.
Does the survey or do any of the other ones that are administered in other places allow for a response in terms of gender, like if somebody identifies as transgender or any of the other
So that's
options?
a good question. It's not in the script, I believe, but they do ask, what do you identify, male or female?
Okay.
That's what they, and then they...
Like data on that group, we wouldn't have.
Yeah, we have not, so no, we don't have that
What
data.
about in terms of other ethnicities, like Asian or
So we do.
American?
They go deep into that. However, when you break it down by demographics, the more you break it down, the more unstable the data becomes, especially since we don't have a large sample size. So if we were to aggregate the years together, we could look at it by ethnicity, right? If we had a large enough, I think it had to be 50 in each cell, then we could look at it. But because we only had a sample of 2,187 and 49% of them are identify as black, about 40% identify as white, and then the Hispanic and other population, it's less, it's like 3% and then 11%, something like that. So we can't break that down further without the data becoming unstable. Yes.
What about data for adolescents and children who are maybe not answering the phone?
Yeah, and that's why the data was broken down into 18 to 44, because we're still trying to capture the data. Again, becomes unstable if we break it down further, 18 to 24 or 18 to 34. Some things we can see, but just to make this more generalizable so that I could keep it the same through each health indicator, that's why I left the 18 to 44. But I can run that for you. I'm available to run that for you.
And there's the YRBS.
The YRBS, yes.
Yeah, if you're asking about children,
Under 7, yeah.
and the complement to this at the PRC is the Youth Risk Behavior Survey that's conducted in schools every year. And there's a complimentary website
Right, yeah.
here on our website that has all of the youth data in a very parallel fashion with trend,
Yes.
Topic area,
Yes.
demographics, and comparison to state and national.
Yes, I modeled this a lot off of the YRBS, kind of. The buckets are the difference, but yeah. Did I see a hand? Yes.
Just a compliment. It's just really, I've been looking for years for updated tobacco use data. And I mean, I just got it.
Yeah, you could,
on the
yep.
website, like,
Yep. That's what we want, yay! Yes. Yeah, we just wanted to get it out. It's been a long time coming. We've been trying, and finally I just had to put everything else on the back burner and just do it. And I'm glad. I'm happy with what it shows. I am happy about it. Anybody else want to see something or have a question? Yeah.
Are you going to be able to track who accesses these data? I mean, that kind of goes back to a question of, who would be requesting it. But
We're working on it. Susan and I are working on it, trying to figure out how eSchoolView can track the clicks. We can track clicks on like data briefs and things like that, reports. We can track those clicks, but actually looking at the data, that's why I'm hoping, well, the data inquiry page won't capture, of course, all of the clicks, because people aren't just going to, every time they visit, they're not going to ask a question, but we're trying. That's the next step. We're working on that. Yeah.
Google Analytics will tell us who clicked on to the demographic data page, but at this point, our web server company does not allow us to count downloads of PDFs, and I'm trying to convince them that that is possible.
Right.
But so we can really see who's visiting the BRFSS site, and while we don't know maybe which of the little circles they clicked on, we do know, okay, well, this many people will visit the page once they're here.
Yeah.
I'm just wondering, and this may be way beyond, what you envisioned for it, but a little pop-up at the end, or just during when people are cruising around, did you find what you're looking for?
Yeah.
Get something that would classify, what we could just comment on what sector you represent. And if you want more help. Thank you.
Yeah, I like that. I'm going to write that down.
I mean, not everybody's going to fill it out, but if it's short enough, it might be useful. I don't know. Maybe
Yeah.
better ideas of what one or two things on there would be. We could do that.
Yeah, I made that note.
A suggestion?
Yes.
Have you had an opportunity to share this with City Council and County Council folks?
No.
Not yet.
Not yet.
I think that's
We had
huge,
some, go ahead.
a huge opportunity there, as well as with GCP and the school systems. Because oftentimes they're looking for this type of data about the clients that they serve. And just to be able to help drive their programming, because that's what it comes down to.
Yeah. Now, that was touched on a lot in our NOCA Ties meetings. We have a couple members that are very interested in getting this to City Council. And
right. So my next point was that that's then where the funding would come, and if they could use this information as a part of how they make their decisions, then it becomes part of the line item within their budgets. Just a thought.
Thank you. Great comment. Yeah.
Is there, so when we're looking at how it's broken down by demographics, is there any way to cross-reference it? So say, see how race or ethnicity and income status might interact?
Yep. And that would be something that you could ask in that data question page, because I can run it like that. It was hard. I wanted to keep it kind of uniform.
Oh, yeah.
So I didn't break it down further than that. But yes, I can do that. Is that it?
On hospitals, add that to the list.
Yes, ma'am.
So that they can, check, they can overlay their own individual data across the county, see how their clients are measuring up.
Oh, wait, one more question, yeah?
Is there data set about about oral hygiene behaviors, whether people brush their teeth, whether they can afford a toothbrush or toothpaste?
Yeah. We did not ask that question. We only asked, have you been to the dentist in the past year, 12 months? How long has it been? But that is, if this keeps coming up, that might be another question that we add in the next administration.
Does anybody have a module for that? Is there a dental module that maybe other states are using?
Maybe that other states. I know when I went on the prevalence tools on the CDC website, oral care was not a large, I think it only asked that question. Again, it's important with the asking the right questions, right?
We also have interest. There's a statewide BRFSS group that actually contributes to OVH's development of the statewide survey.
Okay.
And I believe an oral health module has
come up. Okay,
but
there we
whether or not
go.
it was ranked highly enough, and if there was funding
That's
for
what it is,
So
yeah.
that's typically also what makes the decision at the state level.
That's it.
If those items get added.
Yeah, I believe it's included. I don't think they asked about brushing though, and things like health, like the behaviors that are associated with oral hygiene and oral care.
People who are not going to the dentist may be brushing more often.
Yeah. True. Right? You would think maybe they're like, at least if I brush my teeth, that's it, right? Okay. Well, you guys do have access to this at your fingertips now. The website is live, so feel free to access it.
like to thank everybody for coming, but please join me. Really exciting, and I hope you all get a chance to just, in your own time, kind of cruise around and send feedback. You can use that sheet just to send ideas, feedback, etc.
I will stay around if you have any more questions. Thank you, guys.